Welcome to another episode from the Veterinary Medicine Digest. Today, we are delving into a topic that is all too familiar in veterinary practice, a condition that can be challenging to diagnose, difficult to manage, and deeply worrying for pet owners: pancreatitis in dogs. We will explore the intricate workings of the pancreas, uncover what happens when this vital organ becomes inflamed, and navigate the complex landscape of diagnosis and treatment, drawing on the latest scientific literature to shed light on this serious disease. Let's begin our journey by understanding the pancreas itself. Located in the cranial abdomen, nestled close to the stomach and the first part of the small intestine called the duodenum, the pancreas is a glandular organ with a dual personality. It has two crucial jobs that are tightly interwoven: digestion and metabolism. To understand pancreatitis, we must first appreciate this dual role. The bulk of the pancreas, about 98% of its mass in dogs, is made up of exocrine tissue. This exocrine portion is arranged in clusters of cells called acini, which are responsible for producing powerful digestive enzymes. These enzymes, such as trypsin, lipase, and amylase, are initially created in an inactive state, what we call zymogens, and are stored safely within granules in the acinar cells. When your dog eats a meal, these enzymes are secreted through a duct system into the duodenum, where they are activated to break down fats, proteins, and carbohydrates. Now for the other 2% of the pancreas. This is the endocrine portion. Sprinkled throughout the exocrine tissue are small islands of hormone-secreting cells, known as the pancreatic islets or islets of Langerhans. Though they make up less than 5% of the total pancreatic mass, their role is monumental. These islets contain different cell types, most notably the beta cells, which produce insulin, the hormone essential for regulating blood glucose. In dogs, these vital beta cells make up the vast majority of the islet population, somewhere between 60 and 87%. Smaller numbers of alpha cells produce glucagon, which raises blood glucose, and delta cells produce somatostatin. This intimate anatomical arrangement, with the delicate endocrine islets embedded directly within the powerful enzyme-producing exocrine tissue, is a marvel of biological efficiency, coordinating the digestion and assimilation of nutrients. However, this close relationship can also be considered a potential design flaw. The islets are incredibly vulnerable to any injury or inflammation that occurs in the surrounding exocrine tissue. If the safeguarding mechanisms that normally prevent digestive enzymes from becoming active inside the pancreas fail, the organ can begin to digest itself. This process, known as autodigestion, can easily damage the adjacent endocrine tissue, leading to beta cell dysfunction or outright loss, which can in turn trigger the development of diabetes mellitus. So, what exactly is pancreatitis? In simple terms, it is inflammation of the pancreas. This inflammation occurs when those safeguarding mechanisms we just mentioned fail, and the digestive enzymes become activated prematurely, right inside the pancreas instead of safely in the duodenum. This inappropriate activation initiates a destructive inflammatory cascade, causing autodigestion of the pancreatic tissue and leading to further damage. Canine pancreatitis can present as an acute disease, a chronic condition, or an acute flare-up of a chronic problem. It is a spectrum of disease, ranging from mild to severe, and is a significant cause of illness and even death in dogs. Distinguishing between acute and chronic pancreatitis is crucial, but it is not always straightforward because their clinical appearances can overlap. The definitive difference is histological, meaning it is based on what we see in the tissue under a microscope. Acute pancreatitis is defined by inflammation that is, in theory, completely reversible if the dog survives. Histologically, we see features like neutrophilic inflammation, which is an influx of a type of white blood cell, along with swelling known as edema, and tissue death, or necrosis. The potential for complete recovery of both the structure and function of the organ is a key characteristic of acute pancreatitis. Chronic pancreatitis, on the other hand, is characterized by permanent, irreversible, and typically progressive changes. The hallmarks of chronic disease are fibrosis, which is the formation of scar tissue, and acinar atrophy, which is the wasting away of the enzyme-producing cells. These changes lead to a progressive reduction in both the exocrine and endocrine function of the pancreas. The inflammatory cells in chronic pancreatitis are often lymphocytes or a mix of mononuclear cells, rather than the neutrophils that dominate in the acute form. Unfortunately, a dog with chronic pancreatitis can suffer periodic episodes of severe clinical disease that look just like an acute attack. In fact, it's now believed that many dogs presenting with what appears to be a severe, acute bout of pancreatitis may actually have an underlying chronic condition that has been simmering subclinically for some time. One study of dogs with fatal acute pancreatitis found that a staggering 40% of them actually had acute necrosis superimposed on pre-existing fibrosis, indicating acute on chronic disease. This highlights a critical point. The clinical presentation does not always reflect the underlying pathology. While historically acute pancreatitis was thought to be much more common in dogs, more recent studies involving pancreatic histology have revealed that chronic pancreatitis is actually quite common, but it often presents with acute clinical signs. To make matters even more complicated, it is suggested that many cases of chronic pancreatitis actually begin as recurrent, acute disease in both humans and dogs. A single bout of acute pancreatitis might resolve completely, or it might recur. If it keeps recurring, the repeated damage can eventually lead to the irreversible fibrotic changes of chronic disease. The gold standard for definitively diagnosing pancreatitis and classifying it as acute or chronic is histopathology. However, obtaining a pancreatic biopsy is an invasive procedure with associated risks, especially in a critically ill patient, so it is often not performed in clinical practice. This lack of a readily available gold standard is a major hurdle in veterinary medicine and makes it difficult to design studies and compare findings consistently. This is why researchers are working on developing clear, consensus histological standards for pancreatic disease in dogs and cats, much like what has been done for liver disease. In the absence of histology, clinicians often make a presumptive diagnosis based on a combination of clinical signs, blood tests, and diagnostic imaging. Let's dive deeper into what is actually going on inside the pancreas during an attack. The pathophysiology, or the functional changes associated with the disease, is incredibly complex and still not fully understood, especially in naturally occurring cases in dogs and cats. Much of our understanding comes from experimental models and human medicine. The central event in most cases is believed to be that inappropriate, early activation of digestive zymogens, particularly the activation of trypsinogen to its active form, trypsin, within the acinar cells. Once trypsin is active, it sets off a chain reaction, activating other zymogens and leading to the autodigestion and severe inflammation that define the disease. This inflammation is not just localized. The release of pro-inflammatory cytokines, like tumor necrosis factor alpha and various interleukins, can trigger a systemic inflammatory response. This systemic response involves the activation of neutrophils and monocytes, which can damage the lining of blood vessels throughout the body, causing tissue swelling and oxygen deprivation. Organs with extensive capillary beds, like the lungs and kidneys, are particularly susceptible to this collateral damage. In severe cases, this can lead to multi-organ failure, which is a major factor associated with mortality in both humans and dogs with severe acute pancreatitis. Another contributory mechanism is the development of what is known as endoplasmic reticulum stress within the acinar cells, which can trigger programmed cell death or apoptosis, contributing to cell injury and inflammation. Given the destructive potential of these enzymes, it is no surprise that the body has multiple layers of protection to prevent premature trypsin activation. Trypsin is stored as the inactive zymogen trypsinogen. Within the zymogen granules, there is also an inhibitor called serine peptidase inhibitor Cazal type 1, also known as pancreatic secretory trypsin inhibitor, which can bind to and inactivate any small amounts of trypsin that might become active prematurely. However, it seems this inhibitor is expressed in large amounts only during ongoing inflammation, acting more as a protective mechanism during an attack rather than a primary preventative. Disruption of these intricate protective mechanisms through genetic factors or environmental triggers is what ultimately underlies the development of pancreatitis. This brings us to one of the most clinically significant and intricate aspects of this disease, its relationship with diabetes mellitus. As we discussed, the endocrine islets are sitting ducks, embedded within the exocrine tissue. When the exocrine pancreas is inflamed, the beta cells are caught in the crossfire. Pro-inflammatory cytokines released during pancreatitis can directly damage beta cells and have also been shown to inhibit insulin release. Over time, this bystander damage can lead to significant beta cell loss, insulin deficiency, and the development of diabetes mellitus. This condition, where diabetes mellitus is associated with disease of the exocrine pancreas, is now recognized as a specific entity. In human medicine, it has been called pancreatogenic diabetes or, more recently, type 3C diabetes. For our purposes, we can refer to it as pancreatitis-associated diabetes. In dogs, postmortem studies have found evidence of pancreatitis in anywhere from 13 to over 30% of diabetic patients, suggesting this link is a significant and perhaps under-recognized contributor to the disease in dogs. A pilot study even showed that dogs with naturally occurring pancreatitis had a blunted beta cell response to stimulation, which points to impaired glucose regulation as a consequence of the exocrine inflammation. The evidence seems to suggest that pancreatitis typically precedes the development of diabetes mellitus in dogs. However, the relationship may be a two-way street. Hyperglycemia, the high blood sugar characteristic of diabetes, can itself create a pro-inflammatory state that could contribute to or worsen pancreatic inflammation. For instance, high glucose levels have been shown to activate pancreatic stellate cells, which are cells that can lead to the production of fibrotic tissue within the pancreas. So, it is plausible that in some cases, diabetes may contribute to the development of pancreatitis. Now, let's explore the crucial question: what causes pancreatitis in dogs? The reality is that in most cases, the specific cause remains unknown. Pancreatitis is now viewed as a complex disease, often resulting from an intricate interplay between genetic predispositions and environmental factors. It is very rare for a single factor alone to be the cause. Genetics certainly play a role, as evidenced by the recognized breed predispositions. Certain terrier breeds, such as the miniature Schnauzer and Yorkshire Terrier, are known to be at increased risk. One pathology study in the United Kingdom found that Cavalier King Charles Spaniels, Cocker Spaniels, and Border Collies appear to have an increased risk of chronic disease. Research into the specific genetic mutations is still in its early stages in veterinary medicine. Much of the focus has been on the gene for serine peptidase inhibitor Cazal type 1, the trypsin inhibitor we mentioned earlier. Studies in miniature Schnauzers have yielded conflicting results about its association with pancreatitis risk, which might be due to a complex mode of inheritance where this gene acts as a disease modifier rather than a sole cause. Other genes that have been linked to pancreatitis in humans, like those involved in cystic fibrosis, have been explored in dogs, but have not yet revealed a clear association. Environmental and other risk factors are also critically important. Diet is one of the most frequently discussed factors. Dietary indiscretion, like getting into the trash or eating an unusually fatty meal, has been identified as a potential trigger. Obesity is also considered a risk factor. High levels of triglycerides in the blood, a condition called hypertriglyceridemia, is a known cause of recurrent acute pancreatitis in both humans and dogs, and is particularly common in miniature Schnauzers. The exact mechanism is not fully understood, but it is thought that pancreatic lipase might break down the triglycerides into free fatty acids within the pancreas, causing direct acinar cell damage. Certain drugs have also been associated with pancreatitis, including some anti-seizure medications like potassium bromide, immunosuppressants like azathioprine, and the chemotherapy agent L-asparaginase. Concurrent endocrine diseases are also a significant risk factor. Dogs with Cushing syndrome, or hyperadrenocorticism, and diabetes mellitus have an increased risk of developing pancreatitis. Even hypothyroidism has been associated with an increased risk of fatal acute disease in one study. Finally, any condition that reduces blood flow to the pancreas, known as ischemia, can cause pancreatitis. This can happen in cases of severe trauma, shock, or even during certain surgeries. Diagnosing canine pancreatitis remains a significant challenge for veterinarians. There is no single, perfect test, and the clinical signs are notoriously nonspecific. The most common signs reported are anorexia, vomiting, weakness or lethargy, and abdominal pain. Some dogs may exhibit a characteristic prayer position with their front end down and rear end up in an attempt to relieve abdominal discomfort. Diarrhea can also be seen. However, these signs can be associated with a myriad of other gastrointestinal and systemic diseases. Physical examination findings are similarly variable and can include dehydration, abdominal pain on palpation, fever, or even shock in severe cases. Because of this, diagnosis relies on integrating information from the patient's history, clinical signs, and physical exam with the results of laboratory tests and diagnostic imaging. Routine blood work, like a complete blood count and serum biochemistry profile, can provide clues. We might see evidence of dehydration, such as an increased packed cell volume or a stress response in the white blood cell count. Increased liver enzymes are common, reflecting secondary reactive changes in the liver or obstruction of the bile duct as it passes through the inflamed pancreas. Azotemia, an increase in kidney values, may also be present due to dehydration or acute kidney injury caused by the systemic inflammation. For a long time, veterinarians relied on measuring the serum activity of the enzymes amylase and lipase. However, these tests have proven to have suboptimal performance. The main issue is a lack of specificity. These enzymes are produced by other tissues in the body besides the pancreas, so elevated levels do not necessarily point to pancreatitis. Dogs that have had their pancreas completely removed can still have considerable serum amylase activity, which clearly demonstrates this point. Therefore, measuring total serum amylase and lipase activity is no longer considered a routine part of the diagnostic approach for pancreatitis in dogs. The diagnostic landscape changed significantly with the development of immunoassays that specifically measure canine pancreatic lipase. This is a form of lipase that originates only from the pancreatic acinar cells. During pancreatic inflammation, large amounts of this enzyme are released into the circulation, making it a much more specific biomarker for pancreatitis. Several of these assays are now available, and it's important to understand the differences between them. The benchmark laboratory assay is an enzyme-linked immunosorbent assay, commercially known as SPEC canine pancreatic lipase. This is a quantitative test, meaning it gives a specific concentration of the enzyme in the blood. It is highly repeatable and is not affected by common sample issues like lipemia, hemolysis, or icterus. The established reference interval suggests that a concentration greater than or equal to 400 micrograms per liter is highly suggestive of pancreatitis, while values between 201 and 399 are considered equivocal, meaning they fall in a gray zone that may require repeat testing. Clinical studies have shown this test to have good sensitivity and specificity, although performance can vary depending on whether the reference standard used for comparison is histopathology or a clinical diagnosis. It is important to note that the sensitivity appears to be lower for chronic pancreatitis, possibly because a fibrotic, atrophied pancreas leaks less enzyme. To provide faster results in a clinical setting, several patient-side or point-of-care tests have been developed. The SNAP canine pancreatic lipase test is one of the most common. It is a qualitative test, giving a normal or abnormal result based on a color change compared to a reference spot. An abnormal result on the SNAP test corresponds to a SPEC canine pancreatic lipase concentration of 200 micrograms per liter or greater, which includes the equivocal range. This means a positive SNAP test should ideally be followed up with a quantitative test like the SPEC canine pancreatic lipase to confirm the diagnosis and establish a baseline for monitoring. While it is quick and convenient, studies have shown it has a lower specificity compared to the laboratory assay, meaning there is a higher chance of a false positive result. More recently, other quantitative point-of-care assays have become available, such as the VetScan canine pancreatic lipase rapid test and the VCheck canine pancreatic lipase assay. These offer the advantage of providing a numerical value quickly in the clinic. Studies have shown that the VCheck assay has near-perfect agreement with the SPEC canine pancreatic lipase assay, making it a reliable tool for both diagnosis and monitoring the progression of the disease. In addition to these immunologic assays, there are also catalytic lipase assays that are often included on routine biochemistry panels. These assays measure the enzymatic activity of lipase using specific substrates. The most common one used today uses a substrate called 1,2-laurylare-C-glycero-3-glutaric acid 6-brimethylresorphin ester, commonly referred to as a DGR lipase assay. While these assays are fast and cost-effective, studies suggest that the DGR substrate is not exclusively hydrolyzed by pancreatic lipase, meaning it may lack some specificity. For instance, lipase activity measured by this method can still be detected in dogs with exocrine pancreatic insufficiency, who should have negligible levels of pancreatic lipase, and levels can be increased by non-pancreatic conditions. It is also crucial to recognize that pancreatic lipase concentrations can be increased in dogs with diseases other than primary pancreatitis. For example, dogs with kidney disease, both acute and chronic, can have elevated lipase levels. The interplay between the kidneys and the pancreas is complex and not fully understood, but it is not simply due to decreased clearance of the enzyme by the kidneys. Increased pancreatic lipase has also been reported in dogs with congestive heart failure, which may be due to subclinical pancreatic injury from poor tissue perfusion or pancreatic swelling. As mentioned before, dogs with endocrine diseases like diabetes mellitus, particularly with diabetic ketoacidosis and Cushing's syndrome, frequently have increased lipase concentrations, which may reflect concurrent subclinical pancreatitis. Therefore, An increased pancreatic lipase result should never be interpreted in a vacuum. It must always be considered in conjunction with the dog's clinical signs and other diagnostic findings. Diagnostic imaging is another cornerstone of the pancreatitis workup. Abdominal radiographs can sometimes show subtle signs like decreased detail in the cranial abdomen, suggesting inflammation, but their main role is often to rule out other causes of acute vomiting, like an intestinal obstruction. Abdominal ultrasound is the imaging modality of choice. The classic ultrasonographic findings consistent with acute pancreatitis include a pancreas that appears enlarged and hypoechoic, meaning it looks darker than normal tissue, surrounded by hyperechoic or brighter mesenteric fat, which indicates inflammation. Free fluid around the pancreas may also be seen. However, the sensitivity of ultrasound for detecting pancreatitis is highly variable, reported anywhere from 43 to 89%. The findings can be subtle. The pancreas can be difficult to visualize due to overlying gas in the stomach or intestines, and the interpretation is highly dependent on the skill and experience of the operator. One study found that to achieve high specificity, 3 separate ultrasonographic abnormalities needed to be present. If only one was required, the specificity was quite low. More advanced imaging techniques are also becoming more common in veterinary medicine. Computed tomography angiography, or CTA, uses contrast material to evaluate blood flow and provides a rapid and complete evaluation of the entire pancreas. Studies have shown it can be superior to ultrasound at identifying severe pancreatitis and complications like portal vein thrombosis. Other emerging modalities include contrast-enhanced ultrasonography, which uses microbubbles to assess perfusion, and elastography, which assesses tissue stiffness. Finally, we have direct sampling of the pancreas through fine needle aspiration for cytology or surgical biopsy for histopathology. While many clinicians are hesitant to put a needle in an inflamed pancreas, studies suggest the complication rate is very low. Cytology can be useful, especially when a pancreatic tumor is a possibility, and can show inflammatory cells and necrotic debris. Histopathology, as we've said, is the gold standard but is rarely practical. A key limitation of sampling is that pancreatic lesions can be highly localized, so a single sample might miss the affected area, leading to a false negative result. Once a diagnosis of pancreatitis is made, what can we do for these patients? Historically, and still to this day, management relies heavily on symptomatic and supportive standard of care, as there has been no specific treatment available that targets the underlying pathophysiology of the disease. This supportive care is crucial and consists of several key components. Fluid therapy, usually intravenous fluids, is essential to correct dehydration, replace ongoing fluid losses from vomiting or diarrhea, and improve blood flow to the pancreas and other vital organs. Pain management is critically important, as pancreatitis is known to be a very painful condition. Antiemetics and anti-nausea medications are used to control vomiting and improve the dog's comfort. Nutritional support is also a vital part of treatment. The old approach of withholding food is no longer recommended. Instead, early nutritional support with a low-fat diet is encouraged to help maintain gut health and provide the necessary calories for healing. While supportive care remains the foundation of treatment, the lack of a specific therapy has been a major frustration for veterinarians. However, the tide may be turning, with promising new treatments on the horizon that directly target the inflammatory processes of the disease. One such novel therapy is a drug called Fuzapladib. Fuzapladib is a leukocyte function-associated antigen type 1 activation inhibitor. That is a mouthful, but what it does is inhibit the activation of neutrophils, the white blood cells that are key players in the inflammatory cascade. By blocking their activation, it prevents them from adhering to blood vessel walls and migrating into the pancreas and other tissues, which could help to decrease the progression of pancreatitis and reduce systemic inflammation. A recent multicenter, randomized, masked, placebo-controlled study evaluated the safety and clinical response to Fuzapladib in 61 dogs with presumptive acute pancreatitis. The study found that the drug was well tolerated and safe. To assess clinical improvement, the researchers used a modified clinical activity index score, which evaluated parameters like activity level, appetite, vomiting, abdominal pain, and dehydration. The results showed that dogs treated with Fuzapladib had a significantly greater improvement in their clinical scores over 3 days compared to dogs who received a placebo alongside standard care. This suggests that Fuzapladib has a favorable clinical effect, although the study did not evaluate its impact on survival or duration of hospitalization, which are important outcomes that need further investigation. Another innovative approach being explored is the use of membrane-free stem cell extract, or MF-stem. This is a protein mixture and other bioactive molecules derived from human adipose stem cells. Stem cells are known for their anti-inflammatory and regenerative effects, and this extract aims to harness those properties. It is believed to work by modulating the body's inflammatory response, suppressing the secretion of pro-inflammatory cytokines while increasing anti-inflammatory ones. A recent clinical study in South Korea compared dogs with pancreatitis who received conventional therapy alone to those who received membrane-free stem cell extract in addition to conventional therapy. The results were quite striking. The survival rate in the group that received the stem cell extract was 92%, compared to only 46% in the control group. The dogs treated with the extract also showed significant decreases in their canine pancreatic lipase and C-reactive protein levels, which is a marker of inflammation. No adverse side effects were observed. These findings suggest that this stem cell therapy could have a powerful effect on increasing the survival rate of dogs with pancreatitis, likely by tamping down the dangerous systemic inflammatory response. Looking even further into the future, the concept of precision medicine may one day be applied to pancreatitis. With a greater understanding of the genetic, histopathological, and environmental factors that contribute to the disease, we could potentially develop highly specific therapeutic approaches. This might include things like monoclonal antibody therapy targeting specific inflammatory molecules, or antifibrotic therapies to prevent or reduce the scarring seen in chronic pancreatitis. In conclusion, pancreatitis in dogs is a common, complex, and clinically challenging disease that ranges from a mild, self-limiting illness to a severe, life-threatening systemic crisis. Its intricate relationship with diabetes mellitus adds another layer of complexity for clinicians and owners. For years, our ability to manage this disease has been limited to supportive care, but we are now entering an exciting new era. Advances in diagnostics, particularly the widespread availability of specific pancreatic lipase assays, have greatly improved our ability to identify the disease accurately and quickly. And now, with novel therapies like Fuzapladib and membrane-free stem cell extract showing real promise in clinical trials, there is new hope that we will soon have targeted treatments that can alter the course of this devastating disease, improve clinical outcomes, and, most importantly, increase the chances of survival for our canine patients. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.